So the next case study will be about herpes zoster, which is I consider a dermatology topic. So let's get to highlighting a brief discussion as the pathophysiology, epidemiology, etiology, and the subjective and objective assessments when managing these children with herpes virus. Previously, I've discussed herpes simplex. Now it's herpes zoster. The herpes viruses include the herpes simplex virus and herpes zoster, and they lie in the DNA site. Diseases such as shingles, herpes, varicella, infectious mono, and are also seen in Burkitt's lymphoma. Herpes zoster, also called shingles, involves the reactivation of the varicella zoster, and the presentation will begin with the pathoepidemiology etiology assessment plan implementation. The herpes zoster, also called shingles, is caused by the herpes virus, varicella zoster. The primary infection is the varicella type, and the virus remains latent in the trigeminal region and the dorsal root ganglia, and then years later it is reactivated during a stressful situation. The patho of varicella zoster involves affecting the nasopharyngeal region, and they are transmitted via respiratory drop. So in other words, the varicella allows the emergence of infection by inhibiting multiple host defenses, and then they will overcome the host's local immune-mediated defenses. Once the rash develops, the varicella infects the nerve endings in the skin and then along the sensory axons to establish to later appear as shingles or herpes zoster. So it occurs mainly in adults. It's found 5% of the herpes virus cases involve children younger than 15 years old. The course of the disease in children with an immune defect involves a complex process. It requires usually IV treatment with antiviral agents if they get worse, and the chickenpox continues through lifetime in the sensory nerve ganglia and reactivates to become herpes zoster. Epidemiology is the use of varicella vaccination. It is speculated that it increases the incidence of herpes zoster in adults, and the concern was that the exposure to varicella promotes the varicella virus-specific immunity in adults, and that when this is halted, the varicella then causes a decline in the T-cell mediated immunity required to maintain the latency of varicella virus in certain ganglionic nerves. This is an idea, and there have been concerns that varicella immunization exacerbates herpes zoster, especially in immunocompromised individuals. That's an interesting read, but it's still being studied. So herpes zoster can occur in people when they have had the varicella vaccine or never had the varicella, and varicella virus is spread by direct contact through droplets. The clinical case, HPI, herpes zoster, can present with vesicular lesions anywhere in the body. Always look for any allergies, any immunizations, especially varicella vaccination, any past medical history if there's any history of varicella incidents, and family history also, which is usually non-contributory. Explore the review of systems. Do they look good? Do they have fever, fatigue, skin? Look for any pain, itching, burning on the skin, any existence of blisters. Herpes zoster can present with vesicular eruptions. For children, it's usually coming from the dermatomal distribution in the thoracic area. So evaluate the head, the eyes, ears, nose, and throat, and also the neck. Neurological standpoint, look for any pain or any paresthesias. Other neurological complications include aseptic meningitis, encephalitis, peripheral motor neuropathy, transverse myelitis, and there's apparently an association between herpes zoster and Guillain-Barré syndrome. Also evaluate for the GI factors, any loss or decrease in appetite, GU factors, any lesions, vesicles in the area, any limitations in movement, does the body hurt, or any malaise. The objective assessment, of course, look at the vital signs, any fever, tachycardia, dehydration, blood pressure, adequate, any pain. General appearance, do they look ill-appearing? Do they have fever, irritability? And herpes zoster has erythematous papules, and after several days, group vesicles or bulli are the predominant manifestations on the dermatological factors, and within 3 to 4 days, the rash becomes pustular, and the rash can be hemorrhagic in immunosuppressed people and people of advanced age. For the eyes, ears, nose, and throat, of course, look for any presence of chorioretinitis, which is the inflammation of the choroid, and a thin pigmented vascular coat of the eye, retina of the eye. Examine the ears and the oral cavity can cause erythema and edema of mucous membranes with singular multiple vesiculars and white ulcerations. Then, of course, look at the neck for any regional adenopathy, neurological factors, any changes in mental status, any hepatosplenomegaly pain on the abdomen, GU, of course, lesions, rash, vesicles in the area. The differential diagnosis for herpes zoster Coxsackie virus infection with hand-foot-mouth disease can be a possible one. Rickettsia, molluscum contagiosum due to the appearance of the vesicle. Varicella zoster should be considered since this is the primary infection, of course. It is then important to know the age of the child and his or her history of vaccination. Any drug reactions can show as macular or maculopapular rash, but this too can be considered as part of the differential diagnosis as well. For the plan, local symptoms are alleviated with compress, calamine lotion, or baking soda. Antiviral drugs, if necessary, such as vidarabine and acyclovir, which is acyclovir is usually being used and should be used within 72 hours to prevent prostherpetic neuralgia. And then herpes zoster vaccination is available for individuals that are more than 50 years of age to reduce the risk of developing herpes zoster and postherpetic neuralgia. In terms of diagnostics, well, immunofluorescence of the vesicular fluid is done. Usually you don't have to. The culture of the vesicular fluid also, and PCR of any tissue or vesicular fluid. In terms of health promotion, good hygiene, isolation of the child during infection is necessary. Don't use same utensils as the child has used. Educate the family about the disease. Preventative measure, reassure the family, of course. Any referrals as soon as you diagnose them through clinical presentation. And of course, if it gets worse, they have to come back to the clinic. Consider cultural considerations as well. I used the guideline from the American Academy of Pediatrics, and these are my references. So I hope this helps anyone who's dealing with a dermatology question of a herpes virus on kids. So I'll see you guys in the next adventure or the next travel.